There are three main causes of thrombocytopenia, or decreased platelet concentration, and they are decreased production, increased destruction, and utilization or consumption. With decreased production, there is often a generalized bone marrow disease that effaces the entire marrow. So you'll see this with myelitis, especially infectious myelitis such as histoplasma, or you can see it with leukemias that efface the bone marrow, as well as myelofibrosis and drug toxicities that are toxic to hematopoietic precursors. Less commonly, there'll be a decreased production of megakaryocytes without any other cell type, and that's so rare that we're not going to focus on it for this class. So in general, for decreased production, look for other evidence of generalized bone marrow disease. So neutropenia, non-regenerative anemia. With destruction, there is immune-mediated targeting of platelets. And when this occurs, we call this immune-mediated thrombocytopenia, or IMTP. Now, just like IMHA, IMTP can be primary or idiopathic, or secondary. Causes of secondary immune-mediated thrombocytopenia include some drugs, infectious agents such as rickettsial diseases and other arthropod-borne disease, and less commonly neoplasia. Just like primary immune-mediated hemolytic anemia, primary immune-mediated thrombocytopenia is a diagnosis of exclusion. So oftentimes you don't find a cause for secondary immune-mediated thrombocytopenia. Plus, you'll see a marked thrombocytosis that's often less than 10,000 platelets per microliter. And this is significant because we don't tend to see clinical hemorrhage, spontaneous hemorrhage that is, until there's less than 25,000 platelets per microliter. So, immune-mediated thrombocytopenia often causes secondary hemorrhage just due to a marked deficiency of platelets. Consumption or utilization thrombocytopenia can occur with hemorrhage, vasculitis, or DIC. With hemorrhage, the platelets are consumed with clot formation and trying to stop the bleeding. With disseminated intravascular coagulation, or DIC, there is activation of the coagulation cascade within the blood vessels, and I should say this is a dysregulated activation of the coagulation cascade, which results in platelet activation and deposition within the blood vessel, as well as fibrin deposition within the blood vessel. So this leads to ischemic events throughout the body and tissue injury and hypoxia. Now, red cells oftentimes can flow through or squeeze through the clot, and when they do, the red cells can fragment or shear on the fibrin strands, and this can result in schistocyte formation on the blood smear. So one of the things we look for with DIC is red cell fragments or schistocytes. Other ClinPath changes that we like to see to diagnose DIC is prolongation of our coagulation times, which is PT and PTT. And you haven't learned about those yet, so I'm just going to stop right there, and you'll learn more about the coagulation cascade later. The third cause of consumption or utilization is vasculitis, and there's lots of different etiologies for vasculitis, but one of them in particular is the rickettsial agents. Remember, rickettsial agents was a cause of immune-mediated thrombocytopenia. Well, there's also thought to be a vasculitis etiology as well.